my argument was based in value of care. The prospective phase 3 randomized study that we have that justifies using anti-EGFR therapy in left-sided RAS wild type is the Paradigm study. But if we look at those data closely, the difference in survival between the two arms is only about 3.5 months. The progression-free survival, which is the time that patients are on the first-line therapy, is equivalent, 13.5 months or so. However, if you look closely at later lines, which we have to do when we're looking at overall survival, you look at what patients got after the first-line therapy, about half the patients, so 45% of the patients in the bevacizumab arm never received EGFR therapy. So these are left-sided RAS wild-type patients who never saw an EGFR agent, anti-EGFR agent during the entire course of their treatment. So my question then is the difference of 3 months because the patient never saw an anti-EGFR therapy, or is the difference because they never saw it in the first-line setting? We do look at data in subsequent settings. I shared data from the Strategic 1 trial and older Canadian study where anti-EGFR agents are given in third line for patients after starting, left-sided RAS wild type, included in those populations, but also, in one of the studies, other patients were included. And those patients, once they receive anti-EGFR therapy in the third line setting, we actually see, in the Canadian study, there was a survival benefit of about 3 months compared to best supportive care. It was 4 to 5 months in that study. In the Strategic 1 study, there was no difference in survival between the two arms. And so I think, it really begs the question of this benefit that we're seeing. Is that because of a lack of use of anti-EGFR therapy in Paradigm, or, because they got it in first-line therapy? So then we have to wonder, because I'm arguing based on value, is there value? Is there any harm in doing it in frontline setting? And that's where I talked about some of the toxicities. The grade 3 rash that we see was significantly higher, obviously, in the anti-EGFR arm. And I shared what that looks like. It can be very debilitating for patients, especially if it's facial and very visible rash. There are other toxicities like diarrhea, electrolyte abnormalities as well, but the rash is significant. And, to think about a patient who has a patient or, people-facing job like sales or, anything like that, that patient will not be able to function. And we have to think about this benefit of 3 months, which could be offered later. Or, this toxicity, which may actually, influence how they function, the quality of their life, maybe their livelihood, maybe the income, the psychosocial effects of it. Why not push that toxicity to later? The second part of the toxicity argument was financial. The anti-EGFR agents are much more expensive than the bevacizumab biosimilar that's available. I also showed data for triple therapy, even if we are using FOLFIRINOX, for a patient who we are thinking maybe want to convert to resection. Even with the growth factors, the cost is less than that of an anti-EGFR agent. So benefit of maybe 3 months at best, that's the data we have so far, and I'm questioning that. Significant toxicity, which is, visible, significant toxicity that can affect quality of life, more expensive, and a question of maybe detriment for conversion to conversion to resection if a patient actually has resectable disease. Those data were shown in the Cairo-5 study. The toxicity was higher. The resection rate, or R0, R1 resection rate, was not necessarily higher in patients who had left-sided RAS wild-type disease, either received chemo with bevacizumab or chemo with anti-EGFR agent. Patients had deeper responses with anti-EGFR agent. However, and the response rate was higher, but that did not look like that did not convert to having increased R0 resections or R1 resections. In fact, the toxicity was much higher, including 2 deaths in the anti-EGFR arm. Similar data was seen in the new EPOC study as well, although those were resectable patients, stage 4 resectable, and there was a detriment in using anti-EGFR therapy. And those, we have to balance all of this. The question to me was, this is a fit patient. So if a fit patient, maybe unresectable up front, are we thinking about resectability? We could, or am I taking that chance away from them by introducing anti-EGFR in the front line? So I think it is one option for RAS wild-type left-sided patient. I don't think it's the only option. I definitely don't think it is the most essential option for patients on the left side. And this has to be, a conversation with the patient, the risk and the benefit, and what the patient would want eventually.